the cloud, yeah.
Record on cloud, and then we'll get a link.
Okay, yeah.
Okay, so it's recording already. Okay, I think we should make a start because we have already started. Okay, guys, good afternoon, good evening, good morning, wherever you are. This is DAO 2002 CPD webinar series and an initiative of Medical College, Pakistan. But now it's very global. We opened this to basically everybody. And thanks to my colleague, Dr. Mansoor Ali, who is a consultant nephrologist here in England, and also one of the speakers today. So the format of the webinars, if you are joining for the first time, that this is a 1 hour session, and there are 2 presentations, 20 minutes each, followed by 10 to 15 minutes for any questions and answers. These webinars are recorded, and we have a YouTube channel. So if you want to watch these again, we put these on our YouTube channel. For the certificates, if you could please email your full name to Dr. Mansoor Ali. Mansoor will share email here in the chat. Mansoor, if you could please just type your email address. So the email address that you see in the chat box is the event organizer, Dr. Mansoor Ali. So if you email him your full name, and we will send you the certificate. Please mute yourself throughout the talks and make sure there's no background noise. And we will make a start. So we are very pleased to have Dr. Rangaprasad from Yorkshire. And Dr. Rangaprasad is a consultant in acute and internal medicine, and also the lead for his trust's thrombosis committee. And very important topic, very relevant. We see venous thromboembolism all the time, every day. So his topic is on update on venous thromboembolism management. So over to you, Dr. Prasad. Thank you.
Hello, everybody. It's nice to see so many people on a Sunday evening. I'm sure you must have a lot of other important work on the weekend, but thanks for taking part in this. I'm trying to work out how to use a Zoom. I'll try my best. Okay. So I'm going to give a brief update on VT management. I only have 20 minutes, so I'll try and do as much as justice as possible. And feel free to, I think the questions are in the end, but feel free to kind of ask any questions in the end. So let's skip this one. So I'm just going to go through a case. I think it's always good to go through a case and see how we can tackle it. So we have a kind of standard patient that we get, 30-year-old male who presents with a pleuritic pain and sudden onset of dyspnea. We do have ambulatory care set up in the United Kingdom, which is more like a day case unit, where we don't necessarily admit patients, even with diagnosis of lung clot or a leg clot. We try and treat them at home with anticoagulation, bring them back for imaging. So he has presented to our ambulatory care unit with those parameters in terms of the vital signs. And we have got lots of scoring systems these days, which are quite useful, especially in the acute sector. So I think in terms of managing a patient as an outpatient, so which one of these, I think, do you think would be useful in terms of managing them as an outpatient? I think you can pretty much use a chat box to give your opinion. I'll try and get the chat box if I can. Just a second. Sorry, just a second. If anybody wants to type their opinion, they can feel free to do. So I think most of you might be familiar with lots of these scores. Some of you have mentioned the PERG score, PESI score, WELL score in your options. So I think all these scores are quite relevant in pulmonary embolism. But in terms of the deciding which patient to manage as an outpatient, what we need is a score which can tell us what is the mortality of the patient in 30 days. So if we look at this, the scoring system, the PESI, or the Pulmonary Embolism Severity Index, is the only one which has evidence to showcase mortality. So a patient with a low PESI score has a mortality of nearly very low mortality of around 1%, which is quite acceptable. The original PESI is a long one, which had many different things. The simplified PESI is a modified tool of that and has got those criteria that I've highlighted there: the age, history of cancer, cardiopulmonary disease, hemodynamic instability with those markers. If they have any of those being present, then we would prefer to treat them as inpatient. So roughly using this tool, we can identify about 1/3 of the patients who don't necessarily need to come into the hospital. We can manage them via ambulatory. Again, this is not a very specific tool. For example, somebody might be 81, for example, but might be very fit and well, and we still treat them as ambulatory. So this is the score that is extremely useful to decide in the initial phase as to who is ambulatory and inpatient management. Now, few of you have commented on the PERC rule or the P rule out criteria, which has recently.
Dr. Prasad, sorry to interrupt you. There are some people waiting in the waiting room. If you just.
Oh, sorry, yeah.
All of them.
Yeah.
That's it. Thank you.
Okay. So, right, okay. So P rule out criteria has gained momentum in the recent time, which is extremely useful. It is the initial step where you can assess a patient and see whether does the patient need to go the pathway of pulmonary embolism investigations. And if they have none of these criteria, there are eight characteristics that are described in this criteria. And if it is negative, then you can pretty much rule out PE. The main thing that you need to remember is this is only useful in those with a very low suspicion, okay? This is for somebody with a well score of around 1.5 or less than 1. You have got a very low index of suspicion. You think it's very unlikely to be PE, but before you go the route of doing D-dimer or imaging, you can use this criteria. And this is as good as having a negative D-dimer. So just to mention, all of these kind of scoring systems, you can obtain them using smartphone apps these days. We have MD Calc or QX Calculate. So you can easily gain access to these scores. We don't necessarily need to remember these scoring system. I'm trying to admit everybody as well. Okay. So the recent NICE guidelines, NICE is the UK guidelines, which encompasses all the entire United Kingdom and is a standardized guidelines for use across the NHS or the National Health Service, has advocated the use of the PERC rule. Again, to emphasize, these are for patients with a low suspicion of embolism. Now, a few of you had highlighted well score as well as a possible utility in terms of the scoring system. The well score is mainly useful to determine who is low risk and high risk in terms of imaging. So if somebody has a low risk on the wells, you could use a D-dimer test, for example, and if the D-dimer is negative, you could pretty much exclude a pulmonary embolism. Whereas those with a high risk, they usually need imaging irrespective of the D-dimer. Just one small point about D-dimer. Again, it's a topic to cover in 20 minutes. We have age-adjusted D-dimer that we use across
let me guess, work.
Yeah. So we use age-adjusted D-dimer across the most of the countries now, especially in the UK. There's most of the guidelines at least advocate age-adjusted D-dimer. So age-adjusted D-dimer is age times 10 is a cutoff rather than the usual cutoff of 500. We advocate using age-adjusted cutoff, which is age into 10. And so somebody with 80-year-old, their D-dimer will naturally be higher with age. And the cutoff D-dimer will be 80 times 10, which is 800. Okay. All right, so moving on actually, and this question is mainly, or this case is mainly to illustrate what is a provoked and an unprovoked venous thromboembolism, because the treatment is quite different in provoked and unprovoked venous thromboembolism. So we have a 45-year-old IT professional admitted with sudden onset of left leg pain and pleuritic pain. He has had a recent travel to Spain from UK, which is about a 4-hour flight journey roughly. his body mass index is on the higher side, and he has underwent ultrasound scan, which demonstrates a common femoral vein thrombus. You don't need to necessarily investigate for a PE because the management wouldn't alter at this stage. So you presume he has a pulmonary embolism as well, given that he has pleuritic pain. So now the question to the audience is, again, you can use the chat box to kind of illustrate what you think. Do you think this is an unprovoked, i.e. a DVT, which is not without any risk factor? Or do you think it's a provoked deep vein thrombosis? Or do you think that it needs more testing? Again, you can type in your message. I think few of you have opted for option 2, unprovoked, provoked. I think a lot of you are going for provoked as the opinion. Mainly, I would believe it's because of the travel that has been highlighted. Now, just going back to what is provoked and unprovoked, it's so crucial in the management of these patients, because unprovoked venous thromboembolism, you're looking at long-term anticoagulation, usually long-term being indefinite period, lifelong pretty much. Whereas with provoked, you're looking at transient period of anticoagulation, which is usually for 3 to 6 months. So provoked clot is one where if you stop the anticoagulation after 3 months, the chance of it recurring is extremely low. So we're looking at something around 3% in 5 years, for example. So the only major risk factor in terms of provoking factor we could consider are things like surgery, especially with a surgical time of more than 30 minutes involving GA, orthopedic surgery, spinal surgery. These have a high risk, they're deemed as high risk for thrombosis. So if you stop the anticoagulation, say 3 months after treatment, you've covered the period around the surgery and the period after, the likelihood of recurrence is extremely low. Then you've got a lot of these minor risk factors, such as I mentioned the flight journey or hospitalization or immobility. These are all soft risk factors and they're quite variable. Now, the flight journey this patient has had was about 4 hours. Usually we deem long haul travel as more than 8 hours. Even with a long haul travel, it's not as strong a risk factor as with a surgery or somebody taking estrogen for medication in a female, for example, or a major trauma. So it is a minor risk factor. Then you have the other group, which is unprovoked, where the risk of recurrence, if you were to stop the anticoagulation at 3 or 6 months, the chance of them getting a clot again in 5 years is extremely high, 30%. And especially with pulmonary embolism, the second episode is usually much more severe than the first episode. So these days, even with the first episode of unprovoked, we tend to prefer long-term anticoagulation, which is indefinite term, even with a single episode, especially in a male patient with a high body mass index. Then you have a lot of these risk factors which we could deem as persistent because you cannot get rid of them, like inflammatory bowel disease, chronic heart failure, malignancy. And these group, they have, again, have a very high risk of thrombosis in the long term, and you would be looking at long-term anticoagulation. Now, going back to our case, sorry, just a second. I would deem him as unprovoked DVT because his travel is there, but it's not as long. It's not a long haul journey, and it's a minor risk factor. Then again, just to emphasize, unprovoked VTE and patients with persistent risk factor, we're talking about cancer-associated VTE or inflammatory bowel disease. These are the groups who have a high risk of recurrence, and I'll be looking at continuing the anticoagulation long-term in this group. Okay. So again, I will give the answer for this. The first annual rate of recurrence in a patient with unprovoked episode in the first year is nearly 10% or over. Okay. Just looking at this graph, the one in the dotted line in the bottom is for those with a provoked thrombus, and those in the bold continuous line on the top is for unprovoked. And we've got the x-axis with the time duration. And if you look at the point of 12 months, the risk of recurrence is 10%. It's a cumulative risk. So over a period of 5 years, nearly 40% of the patients have had a recurrence if it is unprovoked. That's quite a significant proportion. So patients have been doing VTE clinic for nearly 7-8 years. So I tell those with unprovoked, like this patient that I've just described, that you've got 1 in 3 chance of getting a clot in 5 years, what would you prefer? You want to come off the anticoagulation, and invariably, most of them will say, I don't want to experience that again. I would rather prefer to be on long-term anticoagulation. So majority of these patients do end up on long-term anticoagulation. So now that we have proved, or we would deem this patient as an unprovoked DVT because there are no major risk factors. Again, to emphasize, the major risk factors from my perspective are kind of major surgery or major trauma, estrogen therapy, pregnancy, postpartum. These are the only 3 or 4 where I would deem somebody as provoked DVT. There are some which are gray area, like long haul travel, minor immobility for a few days with medical illness. These are kind of gray area. And then you've got a clearly unprovoked ones, like the one I mentioned. I would deem him as clearly unprovoked in nature. This patient again is slightly obese with a slightly high elevated ALT. I just would like your opinion as to, again, to emphasize, if you have any questions, if you leave it till the end, because we've got very short time, I'll use another 5. I only have 7 minutes, so we can answer in the end the questions. So which of these would you prefer for anticoagulation in this patient? Would you go for the traditional low molecular weight heparin and warfarin, or one of the DOACs, which is rivaroxaban and apixaban, or the other DOACs, dabigatran, edoxaban, or low molecular weight heparin alone? Again, I can give your opinion on the chat. I'm having a look. Quite a few would like to do low molecular weight heparin and warfarin. Some of you have preferred DOACs, and dabigatran and edoxaban seems to be quite familiar with few of you. Some of you are mentioning the duration as well, which is good. I think we already discussed that it's going to be long term. And again, dabigatran and edoxaban. I think it might be your familiarity as well. Now, most of the Western countries, at least, I think the drug of choice at the moment is the DOAC, and the preferred DOAC that we use in United Kingdom is rivaroxaban and apixaban, and it has a lot of advantages over others, which I'll emphasize in the next couple of slides. The reason why you use a DOAC such as rivaroxaban, edoxaban, or apixaban is mainly because the risk of bleeding in the long term is much higher with warfarin. Okay, so warfarin is not the first choice. We don't even need to discuss with the patient, you know, you're going to be on warfarin or you're going to be on DOACs. DOACs are the #1 choice, mainly because of the safety profile in the long term. Because with rivaroxaban and apixaban, the risk of bleeding is much lesser. And out of all those DOACs, which we mentioned, direct oral anticoagulants, or NOACs, as some of you might call it, which is rivaroxaban, apixaban, dabigatran, edoxaban, there's a distinction in terms of the management with VTE, which is different from management in atrial fibrillation. Now, just to illustrate the NICE guidelines again, which is kind of national standard UK guidelines, has been updated in March, and they recommend again apixaban and rivaroxaban as a first choice. The reason
Dr.
why—
Prasad, can you let all the participants in, please?
Oh yes, yeah, sorry, yeah.
There are quite a few people saying that we are waiting. Sorry,
yes,
I would have done it, but I am not the host.
No, sorry, yeah.
Just click on admit all, yeah?
Yeah. So I think they're all in, yeah. So the advantages of apixaban and rivaroxaban over dabigatran and edoxaban, mainly in VTE setting, is that they don't need a lead-in phase, whereas with dabigatran and edoxaban, you need 5 days of low molecular weight heparin as a continuing 5 days. In UK, most of us treat them via outpatient, like in day case, in ambulatory. It's difficult to facilitate a low molecular weight injection at home for 5 days. That is one thing. The other main thing, I think, which why we would prefer rivaroxaban, apixaban, or dabigatran, edoxaban, is after 6 months of treatment, if a patient needs extended anticoagulation for long term, as in this patient we discussed, with rivaroxaban, you can drop the dose from 20 milligrams to 10 milligrams, which is half the dose as per the Einstein choice today. And then with apixaban, you can drop it from 5 milligrams twice a day to 2.5 milligrams twice a day. So the evidence so far is that it carries similar efficacy despite dropping the dose, but the risk of bleeding is quite much lesser with the smaller dose. Whereas with dabigatran and edoxaban, we don't have that option of reducing after 6 months. So, and this is where the safety profile is so good as well. We have got 10% risk of recurrence in 1 year, 30% risk of recurrence in 5 years. The risk of bleeding on average is about 1%, 1 to 2% major bleeding with rivaroxaban and apixaban in a year. So overall, I think the benefits of long-term anticoagulation outweighs in majority of the patients with unprovoked VTE. So I would give that option to the patient and say, this is the risk profile. I'd quote them the risk based on the graph I demonstrated earlier. Risk of bleeding is so much. What would you prefer? I've got 1 in 3 chance of getting a clot. That's quite high. I'll go for long-term anticoagulation is the usual answer in majority of the patients that I see in the clinic. That is even with a single episode.
1 more minute, Dr.
Okay.
1 more minute.
Okay, I'm just going to mute everybody. Okay, yeah. So I think I've got a couple of minutes only, so I'll try and do as much as possible. I'll just talk about malignancy for a bit. Again, screening for malignancy there is a history that I've quoted here in terms of the evidence. Initially, the evidence was that 1 in 10 patients have malignancy with those with first presentation of thrombosis. And more recent studies show that it's about 1 in 20. So we slightly moved away from doing a routine CT scan in all these patients unless until they have red flag symptoms. And that is what the NICE guidelines suggest now. There are some studies going on looking at can we identify a cohort of patients who might benefit from screening for malignancy? And one of these scores I've just highlighted there, which is a RIET score, which is mainly based on the age is the key thing there, age of greater than 70. So I'll skip that slide. I think the jury is still out on the malignancy screening. The one thing I would like to highlight is about thrombophilia testing. I can count in my finger how many patients have had done the thrombophilia test. So extremely rarely I do it. It doesn't change the management plan. If it's positive, they're still going to be on long-term anticoagulation. If it's negative, it's unprovoked, still they're going to be on long-term anticoagulation. So it doesn't alter the management. So we don't necessarily waste the money and the resources doing it. One slide I would like to mention in the era of NOACs, where you cannot use the NOACs, is patients with extremely obese. These patients were underrepresented in the trials. So that is where you would probably prefer warfarin patients who are extremely or morbidly obese, or those in where there's pregnancy or end-stage renal failure. I think Dr. Ali will cover. Right, okay. Pregnancy, again, I would like to, for the lack of time, I would like to just mention that none of the scoring systems have been validated in pregnancy. You cannot use a well score. D-dimer, we don't necessarily use it. So we go directly for imaging, especially with symptoms of pulmonary embolism. We go directly for perfusion or a lung perfusion scan or a CT scan. Okay, so massive PE, I think I don't have the time to cover the massive PE today. Just to mention with pregnancy again, D-dimer testing is not useful. However, there is recent years criteria which has been published in New England Journal of Medicine. So watch the space is what I would say. Certain low risk group, we can use D-dimer in pregnancy, but for now we are not using it. Cancer patients, just a brief point on cancer patients. All the NOACs have been studied. Most of the NOACs can be used in cancer patients. The word of caution is that I wouldn't use them in GI cancers because the risk of bleeding is extremely high in GI bleed. So I would prefer low molecular weight heparin. So warfarin is a big no in cancer patients because, as we know, the risk of recurrence of VTE with cancer, as demonstrated in this graph, is much higher in cancer patients compared to dalteparin. So dalteparin is what we have been using, or enoxaparin in the past, low molecular weight heparin. But NOACs have some evidence now in non-GI cancers. Or if somebody has a chemotherapy, then you need to worry about some interaction. So if there is no interaction, you could consider NOAC as a first choice. Convenient for the patient. They don't have to inject themselves for 3 months, for example. If you go on NOACs, it's extremely less cumbersome for the patient. So that's the advantage for cancer-associated thrombosis. Again, I've illustrated a kind of chart or a flow chart where how we can assess patients as to who might benefit from DOACs in this group. Now, last slide, I think because in the COVID world, we have to be thinking of VTE. Now, unfortunately, VTE is quite prevalent in COVID patients, especially those who end up in ICU or severely ill. The proportion of patients with VTE is nearing 50%. So nearly 1 in 2 patients might have VTE, looking at which article you're looking at. And the minimum is about around 30 to 50%. Now, we have adapted an enhanced thromboprophylaxis. So, for example, if somebody is on dalteparin 5,000 units, we are using it enhanced thromboprophylaxis. Instead of once daily, we're giving it twice daily. And that is what we would recommend in these patients because of the high risk of VTE. Have a low threshold for investigating for PE in patients who present with sudden worsening of dyspnea. In COVID patients who are being discharged, come back again a week later, extremely dyspneic, despite the X-ray changes, you still need to think about PE. If you cannot do imaging, you can treat them with treatment dose dalteparin or enoxaparin, and then you can look at investigating them later on. And for patients you're discharging from the ward, we would advocate a long-term extended prophylaxis in these patients because they're coming back with VTE a few weeks down the line or a few months down the line. So we propose in our trust a minimum of 7 days, and those with very high risk on the VTE risk assessment scale, you can go up to quite a few weeks of thromboprophylaxis in COVID.
Dr. Prasad, time
Right.
is up.
So I think I'll have to stop there. Sorry. Sorry if it's quite a big topic and it's very difficult to cover in 20 minutes. And thanks for your patience.
Thank you very much. Very enlightening talk, excellent talk. So our next speaker is Dr. Mansoor Ali. Mansoor, I've made you host so you can share your presentation. Mansoor, can you share your? Mansoor, you're on mute.
Naseem, can you hear me now?
Yeah.
Can you see my presentation, Naseem?
Yes, we can see you now. Excellent. Yeah.
Okay, let me just actually see if I can. Yeah, can you see that?
Yeah.
Hello, good afternoon, good evening, good morning, everyone. Actually, thank you very much, Naseem, and thank you for this great participation. I'm one of the co-chairs of this webinar with Dr. Naqvi, and thank you very much, Prasad, for that enlightening talk. My interest in anticoagulation chronic kidney disease came about 4 or 5 years ago, where I actually had really quite a complex case where the patient actually had been on warfarin, and unfortunately we had quite a lot of complications on warfarin for that patient with end-stage kidney disease. This is where my interest actually starts for kind of actually reviewing the anticoagulation of patients who have got chronic kidney disease. So I'll just start with some kind of actually background. Let me just see if this moves. Sorry, Naseem, it's just not. Naseem, I'm not able to share the screen. Hello, Naseem.
Mansoor, do you want to send the slides?
So
And
I've just made you host. You should be able to
Yeah.
share now.
Yeah.
Yeah.
Yeah, because I was disabled, actually, not sure why.
No, you are host now. You should be able to share.
Okay, give me a second.
Yeah, we can see it now. Yeah.
Okay.
Mansoor, open as a slideshow. This presentation, open as a slideshow. Yeah.
Can you see that now? Yeah.
Yes.
Okay, excellent. So sorry about that, actually. I just had some about that. So chronic kidney disease is a major global health problem, and we are increasingly recognizing chronic kidney disease as a problem, not because of increased awareness of chronic kidney disease, but increased presentation, complications of patients presenting with CKD. CKD is actually closely associated and connected with cardiovascular disease. So if you could see from one of the studies, 69.8% of patients actually with CKD have got chronic cardiovascular disease compared to the 34.8% in the general population. Common causes for CKD, I'm sure you all are aware of diabetes being actually one of the up with chronic kidney disease, and then end-stage kidney disease, hypertension and neurovascular disease, and all these are common risk factors for cardiovascular disease as well. And CKD is usually associated with increased cardiovascular events, mortality, thromboembolic risk, and patients actually with these conditions would require anticoagulation. However, the caveat is that these patients actually present with higher rates of hemorrhage as well. The paradox is that not only the association between CKD and CVD is actually high, but also there is increased risk of hemorrhage in patients who've got declining kidney function. So literally, it's actually a catch-22 where you would want to anticoagulate someone, but also you need to be increasingly aware that these patients would end up with increased risk of bleeding. Now, patients with renal impairment are commonly multimorbid. They actually got CKD associated with diabetes, and patients with diabetes have got increased risk of complications and increased risk of hospitalization as well. Patients with who are elderly or actually got age more than 65 to 75, they've got increasing risk of declining kidney function. Hypertension is a common factor there. And also, do not forget that basically cardiovascular disease as well. Patients with baseline CVD have a higher risk of CKD than those without baseline cardiovascular disease. We've talked about atrial fibrillation. However, atrial fibrillation in the context of CKD poses five-fold increased risk of stroke. Atrial fibrillation could be actually asymptomatic in patients who have got chronic kidney disease. However, it has got a negative sort of impact on the quality of life, including increased risk of stroke and thromboembolic events. Another important slide here, atrial fibrillation CKD, risk of AF and acute coronary syndrome is increased or doubled actually in patients who've got declining kidney function or EGFR of less than 60. Prevalence of AF increases with a decline in kidney function. CKD patients have got 12 to 18% higher risk or prevalence of AF compared to 7 to 8% in the general population in age over 65 years. End-stage kidney disease or dialysis patients have got increased risk of almost about 11.6%. This is actually just a slide from Kidney International, is a visual abstract where patients who've got nephrotic syndrome, increased risk of proteinuria, present with other causes of nephrotic syndrome, membranous or glomerulonephritis nephritis. They usually actually are at increased risk of hypercoagulability and increased risk of thrombosis. And these are the patients you need to actually consider anticoagulation. However, I'll just start with one of the cases. I usually learn from case vignettes, and it's important because the cases actually teach you a lot more than your textbooks. So a young patient who comes in with abdominal pain complains of sometimes occasional flank pain as well, swollen eyes and legs. He's got frothy urine. What's your differential diagnosis? Please do write down in the chat. Okay. So your differential diagnosis will be yes, nephrotic syndrome. But the patient's complaining of abdominal pains. This patient actually, has got some thrombotic risk factor there, especially if they're excreting large amounts of proteinuria. And this patient should actually be screened for renal vein thrombosis. And renal vein thrombosis could be really kind of actually life-threatening in some of these patients and could damage the kidneys and declining kidney functions as well. So it's really important to rule out renal vein thrombosis. The reason I actually wanted to mention about nephrotic syndrome, because nephrotic syndrome patients are at increased risk of thrombosis. Other things that you need to consider in renal patients are the atriovenous fistulas and grafts. They could actually, they could be thrombosed, they could actually get stenosis, and this is where you need to really ensure that you scan the fistulas or you ask the renal physicians to look for other causes, especially in patients who've got dialysis lines could also lead to central venous stenosis and thrombosis. Don't forget, renal patients have got increased risks of actually failure of their fistulas, failure of the lines. They come in with line infections. One line comes down, the other line goes in. So you need to be aware of these risk factors with renal patients. This is a large Danish cohort study, which included 132,000 patients in AF who actually also had chronic kidney disease. This study actually clearly shows and demonstrates that the stroke or thromboembolic risk is higher in patients who have actually got non-end stage CKD compared to the CKD population. And as I said in the beginning of the talk, actually the paradox is the enigma in these patients that there's increased risk of bleeding in CKD and non-end stage CKD patients. What's the link between CKD and cardiovascular disease? Common risk factors, hypocoagulable state. Do not forget your Verco's triad. In cases of uremia, there's dysfunctional platelets, high levels of fibrinogen, and all the other factors which actually alter the endothelial dysfunction, basically, or lead to endothelial dysfunction and a cascade of thrombogenic events. Cardiovascular. Please mute your slide, your sort of flashy screens, please. I'm getting a lot of echoes there. The risk factors for CKD patients are hypertension. Patient can progress from stage 1, 2, 3 to stage 5 in a matter of years, especially with diabetics. They've got a really steep progression and decline in the kidney function, malnourished patient, anemia, microalbuminuria, hyperparathyroidism, platelet hyperactivity and uremia. All these are risk factors for patients developing thrombosis. So let me just kind of give you an overview of the anticoagulants. Unfractionated heparin was actually the choice when I was a trainee going about a decade and a half ago, where we used to kind of actually put IV infusions on all these patients. Unfortunately, or fortunately, actually, we have really moved away from that. It's just because it was too tedious, it was cumbersome. You had to monitor the APTT ratios. You had to do that every 6 hours or so. And we have actually then moved on from there. Enoxaparin, tinzaparin, deltaparin came in the last sort of 10 to 15 years or so. There was actually lots of reservations for the use of these in renal patients, just because most of them had sort of actually a renal clearance. Although a non-renal community were actually using them right, left and center. However, we were quite cautious in the use of the low molecular weight heparins in our renal population. Then they came fondaparinus in the use for ACS patients, and I would actually sort of literally be cautious if I see a patient who's got a renal impairment, CKD stage 4 or 5, and they are on fondaparinus. Again, try to kind of actually use your local trust guidelines in the usage of the low molecular weight heparins when you use for your CKD patients and patients who've actually got other comorbidities or other presentations needing the use of low molecular weight heparins in CKD patients. So warfarin, renal community has been using warfarin for a long time. It has been a preferred choice in the chronic kidney disease patients, especially those with end-stage kidney disease, and I'll tell you why. There has actually been also considerable evidence that anticoagulation with warfarin may not be associated with benefit in patients with end-stage kidney disease, especially people who've actually got AF. And not that you want to ignore that, but equally, you know, the sort of actually the risks may sometimes actually outweigh the benefits in Calcified access, one of the really sort of side effects or complication that we use actually, we see in patients with on dialysis who have been on long-term warfarin. And it's actually a really sort of miserable disease where patients literally have got increased risk of morbidity and mortality with lots of skin problems and deep tissue calcifications. Unfortunately, that leads to increased mortality. And a new terminology that's actually come into being over the last sort of few years or so of warfarin-induced nephropathy. And I actually have seen a lot of this over the last few years, and also with the DOACs as well. Then comes the DOAC. So when you kind of actually want to start a DOAC in a patient with chronic kidney disease, what do you need to consider? So this is for trainees who actually are going to be prescribing the DOACs on ambulatory care units or non-renal wards. Consider the indication, consider actually the stages of your chronic kidney disease for your patient, route of administration, availability of reversal agents, and obviously sometimes actually not have a reversal agent for these newer agents, potential interaction with concurrent medication, especially warfarin, and a lot of medications can actually interact with warfarin, dependence on renal function, and obviously the dosage and monitoring the intervals actually for these patients. Whom do you call? Yes, you may want to consult your friendly nephrologist or a hematologist or your local pharmacist who actually have more information than your nephrology consultant or your hematology consultant. So let's actually start with a case profile. It's a patient profile of a 75-year-old Gwendolyn who has actually got chronic kidney disease, creatinine eGFR about 42 mils per minute, serum creatinine 114, hypertension, and newly diagnosed NV, non-ventricular atrial fibrillation. The only medication she's on is actually enalapril. GP discusses anticoagulation with this patient. When and how should renal function be evaluated in patients who are being considered anticoagulation? There are some guidelines, and they're actually based on the European Heart Regulatory Authority guidelines for monitoring renal function AF. All patients, at least you need to kind of ensure that there's a baseline kidney function. Elderly, more than 75, 80 years old, actually you need to make sure that every 6 months. However, more so if your patient is taking dabigatran because of increased renal clearance. Increased dependency on the renal clearance, actually. What is your renal impairment? You need to kind of actually divide the creatinine clearance with 10. The reason why creatinine clearance is used is because creatinine clearance has been used actually by the pharmaceutical companies to sort of evaluate the efficacy of these drugs in patients with chronic kidney disease. And obviously, you need to kind of actually monitor and measure the kidney functions if there's any intercurrent illness. Now, it's easier done when a patient's in the hospital, but if the patient's actually in the GP land, you don't monitor kidney functions every other day or every other week. So this is where really these guidelines are really helpful for primary care physicians or people who actually are not in the hospital. So again, the European Society of Cardiology guidelines AF, kidney disease, obviously class 1 and class 2A, and you've got to kind of actually base it on reading of the evidence. Or kidney patients who are actually starting on anticoagulation have the kidney functions monitored. In the interest of the time, I will be kind of actually slightly speaking fast and moving through the slides. So Naseem, if you allow me another 5 minutes or so, just because of the delay in the slides that I had. So Gwendolyn's creatinine clearance is calculated to be 40 mils per minute using the Cockcroft-Colt equation. So that gives actually stage 3. Why is it important to take renal function into account when choosing an anticoagulant treatment? This is because literally the clinical pharmacology of warfarin and DOACs. So renal clearance of warfarin is about 8%. This is why it has been used actually literally forever in patients who are on dialysis. However, you see the apixaban, dabigatran, rivaroxaban, edoxaban, literally the renal clearance for dabigatran is about 85%, and for edoxaban is 50%. This is why I, in my clinical practice, I've actually less relied on dabigatran and edoxaban and more on apixaban and rivaroxaban. Now, I'll tell you why I actually may have a favorite of one over the other, and this is because in line of the recent evidence that we have, and I'll share that with you. Again, the half-life increases if you've actually got So Gwendolyn considers all options for anticoagulation with her GP, including warfarin. So I think with her kidney function, CKD stage 3, it is actually literally sort of maybe kind of actually preferable to use a DOAC. Why? We've got some evidence on that. So there was actually literally lots of studies done, Aristotle, Rocket, Engage, and Rely. Now, these studies were done. They're large randomized controlled trials, basically, done to kind of actually literally compare the efficacy of DOACs versus. Sorry, could you mute yourselves, please? DOACs against warfarin, and always done actually testing for non-inferiority. I will not be able to go through all of the studies, but I'll actually just show you.
Mansoor, can you unmute yourself, please? Just unmute yourself, because I've just muted everyone. Thank you. Yes.
Okay, is that better? So
Yeah.
apixaban actually is favorable in CKD patients compared to warfarin. This was from the Aristotle trial. Then there was another trial, which was actually on rivaroxaban. But let me just kind of mention this to you, the NICE guideline. My colleague, Dr. Rangaprasad Karadi, did mention about NICE. So NICE has actually mentioned, consider apixaban in preference to warfarin. It did not say in preference to other anticoagulants, DOACs, but in preference to warfarin with in people or patients who have actually confirmed EGFR of 30 to 50 and have got non-valvular atrial fibrillation or one or more of the following risk factors. The risk factors, as I said, stroke, age 75 years or older, hypertension, diabetes, or symptomatic heart failure. So NICE has endorsed or backed apixaban. This may change in the future based on the more newer studies that we actually get. So dosage is really important in patients with chronic kidney disease. And again, I wouldn't go into dosage because this should be in the SPC. In all hospitals, you may have actually got that on your wards, or the pharmacy may help you about reduction in dose of your DOACs. Apixaban, usually with actually reducing EGFR, you would probably go for 2.5 milligrams BD. For rivaroxaban, it's actually 15 milligrams once a day. Again, I'm just actually showing you that what the NICE guidelines said in 2014 about, based on the Aristotle study, that apixaban actually was more sort of efficacious and safe as compared to warfarin in patients with poor kidney functions. Then there was actually also a KDICO, which is a kidney disease improving global outcome study consensus, which is showing that there was not enough evidence to recommend one DOAC over any other in this particular population of chronic kidney disease, and there was no head-to-head trials to compare efficacy. So remember that point. Again, so rivaroxaban actually versus warfarin, rivaroxaban showed lesser sort of rates of stroke and systemic embolism compared to warfarin. Again, the bleeding was actually sort of less in GFR of more than 50, less than 80. However, it was kind of actually quite close with actually warfarin in terms of it wasn't statistically significant enough with patients who've actually got reduced EGFR, but the CHAT score for patients who were in rocket AF were higher compared to that of apixaban. So bear that in mind. Again, rivaroxaban showed a significant reduction in stroke and embolism with a consistent safety profile in patients with worsening renal function. So managing, last few slides actually I would say about managing anticoagulation of patients with CKD. Renal functions can decline whilst on treatment, so you need to be really kind of actually monitoring these patients closely between yourselves and the, the specialist. Renal functions can transiently be affected if you've got an acute illness, because don't forget, CKD could progress. Patients with CKD are at increased risk of AKI, increased risk of hospitalization, and increased risk of major complications, including cardiovascular disease. Apixaban, doxaban, not recommended in patients with chronic creatinine clearance of less than 15, although this has actually been used, apixaban has been used for dialysis patients less than 15 or on dialysis in the US, but it's not licensed. So if you're using in your dialysis patient, you have to justify that. You need to ensure that you've actually written justification of why you're using in this patient, because the patient may have had problems with warfarin or erratic INRs. So treatment of VTEs in patients with renal impairment. So rivaroxaban, you've got to reduce the dose, especially with lower GFRs, contraindicated and less than 15. Apixaban contraindicated, but used with caution if you've got 15 to 30. Dabigatran on no particular use and on no particular actually experience myself, including edoxaban. So we have talked about how do you kind of actually follow up these patients, including how do you sort of monitor them on a regular basis. 6 monthly, more than 75 years, especially on dabigatran, and literally you can divide your creatinine clearance or GFR, divide them by 10 to kind of actually find out the intervals that you need to monitor these patients on. So evidence, as I said, efficient and safe use of warfarin direct anticoagulants in multimorbid CKD. DOACs preferred in CKD 1 to 3. Stage 4 CKD, again, you need to kind of consult that with your patient, justify why you're using a DOAC as opposed to warfarin. Warfarin remains the first line of treatment in end-stage renal disease, but again, is strictly individualized. Again, there's no randomized controlled trials using the dialysis patients. However, there should be some coming up in the next sort of year or so, but I haven't actually come across of any RCT in dialysis patients. There has been some kind of actually abstracts or sort of local audits where patients have actually been treated with apixaban or rivaroxaban on dialysis. But the jury is still out to kind of actually whether the usage of this is without any increased risk of bleeding. Now, contributors to hemorrhagic risk for these patients in CKD, concomitant drug therapy. Don't forget, these patients have got cardiovascular disease. They may be on dual antiplatelet agents, end-stage kidney disease on hemodialysis. Patients are actually intimately exposed to heparin because on dialysis, and that needs to actually keep going to ensure that the circuit is flowing and there is less risk of clot in these patients. I'll just actually end up with this case number 3. You may want to kind of put that on your chat. An end-stage kidney disease patient on dialysis 3 times a week, admitted with chest pain, treated as ACS with dual A antiplatelets, fondaparinux, and then given also, fondaparinux was actually stopped after a day or 2 and given enoxaparin 1 milligrams per kilogram per BD. Weight of the patient was 110, so you can imagine 110 kilograms twice a day. Within 48 hours, the patient's fistula started bleeding, and in 72 hours, the patient actually had seizures with loss of consciousness and cardiac arrest. Differentials, I'm sure you all have actually guessed it, the differential was a massive bleed, and the outcome was unfortunately sad. So remember that yes, these patients have increased risk of thromboembolic complications, but they're also kind of actually at increased risk of bleeding. Thank you very much.
Thank you, Mansoor. Excellent presentation. So we have about 8 minutes or so, 7 minutes. If anyone has got any questions, you can raise hand, or you can type your question in the chat box. There was a question from earlier on from Raji Kiran Deshpande. Do patients with plus minus persistent risk factor indication for IVC filter, Dr.?
That's a very good question, actually. IVC filter have recently been in the spotlight because they can do more harm than good, actually, in the long term. I've had patients with IVC filter who have ended up with horrendous infra-filter thrombus and post-thrombotic syndrome and ulcers. So the problem with IVC filter is that they are prothrombotic themselves. So just below the IVC filter, you can get a thrombus. And in the long run, the patients get venous leg edema, and they have a significant morbidity in terms of venous ulcers and other complications. So IVC filter, we advocate only using if they have an absolute contraindication for anticoagulation. When we say absolute contraindication, if somebody is actively bleeding or they have a PE and they're having a major surgery at that particular time and you cannot anticoagulate, that's the only kind of absolute indication for IVC filter. Even if you do IVC filter, almost invariably all filters are temporary. So you need to have a clear plan. When you're putting the IVC filter, you need to have a clear plan of removing it at the same time. And if you remove it sooner, then it's much more easier to remove. So we usually make a IVC filter, you need to remove it within 6 weeks ideally, but sooner the better. But only do it if there is an absolute contraindication for anticoagulation. So it's a strict no-no for IVC filter. Very rarely we use it. And I mean, we still use it, but even if you do it, you need to remove it soon after. Thanks.
Sure. Thank you. Mansoor, question from...
Yeah, I've read my questions.
Yes,
actually, I've quite a few questions. So let me just actually answer the first question.
How long do you... No, Mansoor, let me go through the questions. You focus on the answers. Don't do 4 things at the same time. So there's a question from Akin. How long do you anticoagulate patients with nephrotic syndrome?
Yeah, good question, actually. So patients with nephrotic syndrome are, as I said, increasingly at risk of developing actually renal vein thrombosis. So thrombosis could be anywhere in the body. I would actually ensure that their albumin levels are literally above 20. So as long as actually their albumin levels above 20, I would not necessarily kind of actually put them on any anticoagulation because of the increased risk of complication with bleeding. But if they are heavily thrombotic and nephrotic, then yes, usually kind of actually for 6 to 12 months or so, depending on the level of the ailment. So if they are in remission after the treatment of the nephrotic syndrome, because nephrotic syndrome is actually not a sort of actually a diagnosis, it is a complex syndrome, and you need to kind of actually come to a diagnosis, because nephrotic syndrome could be due to malignancy, could be due to minimal change disease, or membranous nephropathy. As I said, actually, in one of the slides I showed you earlier, the visual abstract, most patients usually kind of actually get antibiotic with warfarin, and for a period of 6 to 12 months. But when they are in remission, I would stop the warfarin or stop the anticoagulants such as roxaban or apixaban, depending on their kidney function. But yes, 6 to 12 months.
Okay. So there's a question from Ahmed Nasir. I think maybe both of you could answer. He's asking how to treat post-femoral cath DVT end-stage kidney disease patients on hemodialysis. I think I assume that he's talking about, so you have put a dialysis line through femoral vein, and the patient has developed a DVT and now more dialysis. So duration of therapy?
Yeah, so I actually get this on a sort of a regular basis. I usually actually give them 3 to 6 months warfarin treatment. I would not necessarily kind of actually rescan them, but I would give them at least good 3 to 6 months warfarin. But normally these patients do end up actually having one or the other lines, and then you could, see whether the thrombosis is there or not. I don't know whether Dr. Prasad Karadi has actually come across these patients, but usually it's 3 to 6 months for dialysis patients. I would not leave them longer, especially if it's actually line-associated thrombosis.
Yeah, I would agree with that. Usually 3 months should be sufficient in these patients for anticoagulation. Thanks.
Okay. There's a question from Akbar. I think it's actually a very detailed question, but Mansoor, if you have a quick comment. Warfarin-induced nephropathy. What is that?
Yeah. So warfarin-induced nephropathy, thank you very much, Akbar. I saw your question actually. This is literally a diagnosis of exclusion, I would say, because when you get a patient with acute kidney injury or progressive CKD, you need to kind of actually go through all the other regular common causes of chronic kidney disease or AKI before kind of concluding this is warfarin-induced nephropathy. And usually warfarin-induced nephropathy, actually, depending on what the levels of your patient's INR has been over the last 6 to 12 months or so, they've had erratic INR levels, and also they've actually had increased risk of bleeding from other sides. But the diagnosis is usually kind of actually by doing histology, where you literally see glomeruli filled with actually thrombin or blood, basically, and this is when you kind of actually literally diagnose that this could all be associated with warfarin. Again, it's a diagnosis of exclusion when you've excluded every other causes of patient with AKI and progressive CKD.
Okay, thank you. I think we have time for one last question. I don't know if it's been answered already. It was asked earlier on in the chat from Raji Kiran. Usefulness of modified Caprini score in management of VT over other scoring systems.
That's a very good question. I think we have got a lot of scoring system, like one is the Caprini score that you mentioned and the Padua score. And we have our own Department of Health, a VT risk assessment tool, which we use in the United Kingdom. Again, I don't think there has been, quite a lot of them are promising. So I think whatever you're familiar with, there's another score called as the Improve score as well. You can use it. At the moment, we are still undertaking, I think we have, in UK, we are looking at a trial or looking at all these scoring systems and comparing them. So I wouldn't prefer one over the other, whichever you are more familiar with and you're comfortable using. Again, there's no clear kind of evidence as to which one is the best yet. I think the evidence will emerge in the future, but use the one that you are familiar with is what I would recommend.
Okay, thank you. I think, Mansoor, we have one last question from Deepam Jyoti, and he or she is asking, if dialysis, despite warfarin contraindicated in nephropathy, we would give it for 3 to 6 months warfarin? I'm not sure if I
really did. I did not
understand. Dialysis and warfarin contraindicated, what would you do?
Yeah, yeah, I mean, actually, to be honest, I've just finished my week of on call, and I was on call this weekend as well. I have a patient who's actually literally clearly nephrotic. He is approaching dialysis. His GFR is almost about 9 and 10. It was a very sort of conscientious decision between me and the patient to kind of actually consider continuing on apixaban for the duration until he starts dialysis, and even after that, because this patient has got AF and has had previous TIAs as well. So again, if you could justify that, if you could actually ensure that you've actually explained to the patient the increased risk of bleeding with a DOACs. The patient does not want to go back on warfarin because he had a terrible time with warfarin, lots of hospitals sort of actually admission to increase INRs. And, you know, I had to kind of actually, I wouldn't say succumb in, but it was a mutual agreement on the continued use of DOACs in this particular patient. So yes, I would use DOACs. We haven't got anything else at the moment to kind of actually use. One thing that I want to mention that I've not mentioned in my slides, and I think Dr. Prasad Karadi has actually mentioned, was COVID. So renal patients were, including dialysis patients, were at increased risk of thrombosis during the COVID period that we had in the last 6 months or so. And we were actually increasingly using a high dose of tinzapine in our trust at 125 units per kilogram rather than 175 units per kilogram as a treatment dose for these patients actually who had high D-dimers and who were unwell with COVID, and who had actually increased risk of thrombosis. So yeah.
Yes, thank you very much. Thanks, Mansoor. I think time is up. We had excellent attendance. About more than 83 people actually joined. Fantastic. So the next webinar is on the 15th of November. It's always on a Sunday at 5 p.m. For certificates, Dr. Mansoor Ali is already given his email address. So if you could email him with your full name, and we will send you the certificates, the CPD certificates. Thank you very much again to Dr. Rangaprasad for his time on a Sunday. And we are also for speakers as well. If you know any excellent speaker, then please do get in touch with us. We obviously share these flyers on various different Facebook forums. And I'm sure there are hundreds more, but whichever we are part of in the IMG forums and BAPIO and other forums. So please feel free to share these to other folks in your hospital, and also do give us your suggestions on how to improve these sessions. We'll be recording as soon as it's available on our YouTube channel, and I would like to thank all of you again. And thank you to Dr. Mansoor again for his time. So we'll see you next month on the 15th of November, Sunday, 5 p.m. Thank you.
Thank you very much.
Thank you.
Thank you.
Thank you.